Can you hear me? Yeah? Okay. So I think when you're talking of risk assessment, there's always issue about this perception and reality. So sometimes you actually see the perception, yeah? I've got higher risk of this and that. But what data you have at the back of it? So there is a huge difference between perception and reality. So say, for example, I can give you 2 examples which have nothing to do with infection control. So we have this perception that homeopathic medicine is actually doing me some good. Okay, so how many, can you raise your hand that you have perception the homeopathic medicine, for example, is actually really doing some good? Raise your hand. You. Okay. The reality is there's not a single data. The reality is that this medicine is completely and utterly useless because it has not a single published evidence available. So because the people actually look at the perception that because I have this thing, okay, therefore because the reality is there, they are using it. How many people actually believe that anti-wrinkle cream, where women actually spend millions of pounds, is actually worthwhile? Can you raise your hand? None. Okay, so they have done randomized control trial, leaving the anti-wrinkle cream versus normal cream, double randomized control trial. It's just by massaging, because you're just massaging it, it does it. But the perception of this is, yeah, that it does actually remove the wrinkle, and therefore people sell it. The reality is that you have no data on that. So you don't have this bigger picture. So I think this is very important when you are doing the risk assessment in infection control or anything. There's a perception that's what it is. But is it really true? Because you do not have data for that, okay? So this is what I'm saying. These are not published data. So this is basically jokes. So perception versus reality, I think, is quite important. So over here, when this person looks at it, his perception at the moment is this. The reality is it's completely different because now he's getting the bigger picture of the whole thing. So I think this is very important. You have to actually have the risk assessment. And if you do not have a data, you can't actually do it. And this is the first thing you have to keep in mind. Is your perception the reality? The reality is going to come only when you have data, okay, which is going to come through surveillance, audit, all bits and pieces. Now, this is another thing. So say, for example, there's a crash of jumbo jet. Now, when this happened, suddenly the perception would be what? That it is not really safe to fly an aeroplane. And always the number of flight, when this actually happened, people actually stop flying, okay? But the reality, so that's the perception, right? Because of the one jumbo jet crashing. The reality is actually that airlines are the safest mode of travel, okay? And I think this is very important. So when you're looking at the infection control or your life, any part of your life, is this your perception? What is the reality? So you have to go beyond it, and I'm going to go through this lecture to see how you actually go beyond it. Reason? Because if you are actually acting on your perception, then your direction travel will not be the right, yeah? Because it's the reality you're looking for. Then you are going to reduce your infection, you're going to do certain things. And I think most of the time, say for example, I was just listening to the waste disposal and all, but how many people acquire infection from waste? Do you know the papers? Yeah? What do you think? What's your perception? What's the reality? Yeah. The question I'm asking, the linen laundry, forget about the food. Linen laundry, is it really a big issue? Yes, it's a big issue, okay? So that's your, do you think the perception reality? What data you have, okay? But if you look at the really literature, healthcare waste, if you do it properly, the risk is actually very, very minimal. There's only one paper you can see came from New York, where 4 people acquired tuberculosis. But overall, if you handle it safely, and that's what we were talking about, people don't acquire, much from the waste, you know what I mean, as far as you manage it in the right way. But the other one, remember, the central venous catheter, all bits and pieces, those are the real, because we have got the data on that, you know what I mean. So it's so if you look at this number of patients, 44,098,000 people actually die of United States. So this is, now if I convert this into what we call the jumbo jet unit, what's actually happening, that at this moment, every day, one jumbo jet, it crashes in America every day because of these errors. Is it a news? Okay, no. But this is the reality. So how many jumbo jets crashing in India because of healthcare associated infection? Because we don't have data. So can you see the reality? The reality is this, the perception is we don't have a problem, yeah? So when we are doing the risk assessment and you want to reduce it, this is the thing you have to keep in mind. Is it your perception? Is it your reality? If you cannot have this concept, you will never able to do the risk assessment, infection control, or anything. And I actually go across and, you know, people actually say, you know, I've got a problem with laundry and, you know, I've got this and that sort of thing in African country. I say, look over here. This is not really your problem, I'm sorry to say. Your patient actually dying with Ebola, right, cross-infection. People actually dying with central line infection, you understand. You got 80% C-section rate, pus is pouring out, and you are actually talking to me about the dirty linen, okay? That's the last thing I would actually think of, you know what I mean? So try to control these one, and then the other one, okay? It's just the perception, the reality kind of thing. So what actually happened, what people don't realize, that hospitals are not really safe, okay? They are really, really very dangerous. Now, I'm going to show you a slide. If I actually tell you do bungee jumping, how many people will raise your hand to say you want to do bungee jumping? Okay, very few. Okay, you will do it, okay? So you got more sort of spirited nature. So can you see the bungee jumping? So can you see hospital, healthcare are in the same area where they're bungee jumping. So most people will not actually go to bungee jumping, yeah? But they will actually come to the hospital and they said they love one. Interesting, isn't it? It's the same league. It's bungee jumping and mountain climbing. So hospitals are really, really dangerous place, not only in terms of medical error, but also in terms of healthcare associated infection. So they come in and we give something to them kind of thing. So this is actually quite important. So I think these are all about the perceptions and realities. So if you look at risk management, the first thing I think what you have to do is to evaluate the hazard. So you have to actually think in a very systematic kind of way, because what actually happens day to day, infection control, you've got so many things, isn't it? Yeah? I know in my life, I was actually running like a headless chicken. That I have to do this, and I have to do this, and I have to do this, and I have to do this. So how do I know which is my main priority, right? That's very important. So you have to actually think, which I'm going to go through, you have to think in a very systematic kind of way. Very systematic kind of way in terms of what you're going to do. Say, for example, I'm actually crossing the road, okay? Is there any risk? Yes, there is, okay? But I have to cross the road, so I'll be more careful. But the idea is that I'll be run over or hit by especially over here, the number of motorbikes you have, you know, I'm really scared, okay? So it's just, you can be hit by that, but I have to cross the road, but I have to take extra precaution. The risk is there, but I have to actually, I cannot live by not crossing the road. So first I think you have to do is you have to evaluate the hazard, to see what the hazard is actually. Then you remove the hazard and try to minimize it by adding the control measure. So the primary make of risk management is proactive reduction. Proactive, okay, is proactive reduction of risk which you have in your healthcare facility. And then it's not one thing, it's just ongoing, because if you actually keep your eye off the ball, yeah, then it's going to come back again. It's just like maintaining your car, okay? You have to take your tire pressure on the regular basis, okay? Otherwise it's going to give you trouble. So it's just those things you have to do it on. And the risk management IPC actually divided into 4 bits. It's not the infection risk we are talking. So infection control, you have to actually think into 4 areas. So you have to have this biological, which could be microorganism, which is special in the laboratory. It could be infectious diseases, or it could be HCI. Chemical, I think, glutaldehyde, hypochlorite, any chemical which you are using, yeah, any chemical you are using. So you have to do hazard of that as well. Environment, failure of ventilation, the operating theatre, negative pressure ventilations, isolation, equipment failure, decontamination. So these are all the risks you have. So as an IPC, remember you are dealing with all these 4 risks on day-to-day basis. And you have to work it out to see how you're going to evaluate these. So how do you calculate what is the risk factor? You need some kind of number or some weighting. So the first thing you do, you actually look at the frequency, and then you look at the consequences. So say, for example, if the consequence is actually quite big, and the frequency is very high, that suddenly becomes your priority. If the frequency is very high, but the consequences are very negligible, then when you're actually sitting and thinking about it, then that risk will be actually slightly low. Now, if you do surveillance and audit, it's going to tell you the frequency, isn't it? That what is the problem? Now, remember, so then you calculate all these sort of things, and then you go one by one. And this will actually give you a thing. Because most of the time I go over, people have this 20 things. I've got this, and I've got that, and I've got this. I say, look over here, you cannot do all of this at one go because you are single-handed, or you may not have enough knowledge. You need some additional expertise from outside, okay? And I contact a lot of my colleagues who are actually expert in that particular field. So you have to work it out which is really the priority. And sometimes remember one thing. The priority is not actually set by you as an infection control. It can be set by the government level, right? And you have to do it. And the question, I think yesterday somebody was asking, environmental swabbing, no evidence, but we have to do it. Why? Because of the accreditation. You understand? So sometimes you have to actually do it is because it is not your priority, but it is coming from the governmental body that you have to do it. And now you know that now that become your priority. Not based on the risk, okay, but based on the management issues. So again, you try to separate these one out because there are a lot of things we have to do, unfortunately, in infection control, which we do not actually believe are right, but we have to do it, yeah? So we have to accept that. So just trying to actually separate these 2 issues. And second thing, you have to do the assessment. And the only way you can do the assessment about the impact, what is going to actually happen, is to assess it. So say, for example, if a nurse, and I'll give you example, the real example which happened in the United Kingdom, in whole of Europe, glutaldehyde is completely banned. You cannot buy glutaldehyde. What actually happened some years ago, one nurse was using glutaldehyde to decontaminate endoscopes and got 1.2 million damages. Now with glutaldehyde, when you develop asthma, it's irreversible. So even when you take the glutaldehyde, the asthma persists, and she got 1.2 million damages. Why? Because she was actually working in the area which was not adequately ventilated, and people were not performing monitoring, right? So can you see the consequences were actually quite dire, right? Frequency was quite low, yeah? But consequences was quite dire, okay? The question over here, was it a personal failure or was it system failure? But how many things you think was a personal failure? How many things were system failure? Raise your hand. System failure, yeah. Why it was system failure? Yes, the person was not trained. They don't apply the adequate things, you know what I mean? So she just was doing it. And I think if you look at health service, most of the time when you look at the risk assessment, it's the system failure. It's only 5% people have issues, with him. 95% is also about system which is not right. Okay? So instead of root cause analysis, at the moment we try to actually do what we call the system analysis. Okay? And then you can see lots of recommendation. And I think the consequences I think you do is not actually look at the patient, please. Not look at the patient only, no. You look at the patient, you look at the healthcare worker, but please look at the visitor as well. You know why? Like country like India and lots of other countries, people are coming over as a visitor, right? coming and seeing the patient, they are going back. What happened to what they acquired over there, you have no follow-up. Isn't it, yeah? So try to actually think in a little bit of broader sense in terms of, just don't try to confine to the patients and all these sort of things. In terms of biological, chemical, all these kind of hazards. And then actually you have the script, okay, which is very simple. So what actually happened, you have got this likelihood, possible, probable, and then you have got acceptable, whatever it is. So can you see when you got the extreme risk, that means the consequences are actually quite dire. For example, the case of Ebola, right? It's really suddenly, the red line actually go up to see you don't have it. So you can have low, which you may accept it. You can have medium, you can high, and you can low. And you keep on working from red to yellow zone in that order. Okay? So when you're risking it, applying the risk factor, and you work from low to up. And then, one thing, my advice will be, I don't know what's the cost type of litigation you have. We have risk assessment committee where we log everything. Not only HCI, but everything. So say, for example, as a clinician, you're a surgeon, right? And there's some equipment decontamination failure. You have to log it. And every month we sit over, every week we sit over and look at all this thing. And we quantify the risk at the organization level, okay? And I'm sure you must have some kind of system. But you have to have some kind of system where you have to log the risk. Two things. Now, this is important. Because you as an infection control person or histopathologist or a surgeon or a physician will actually be able to quantify the risk, right? Microbiology risk is we will quantify the risk. Surgeon will not know, differentiate between the Acinetobacter and then the MRSA or whatever, but no, it's actually quite serious because, A, B, C, D. So then these risks are analyzed and we categorize all of this risk. So this is actually quite important. You have to have some kind of committee somewhere to actually quantify risk, so the actions are taken. Why this is important for IPC? Because we have to go to the court, right, as the IPC. So we have to really justify that we have actually highlighted this risk and the consequences and the impact, to the senior management. And if they don't take any action, balls in their court, especially for the extreme risk. Okay? So it's not actually only about the safety, but also making sure that you are covering your back as well as an IPC, okay? Because the litigation now, especially in private hospitals, worldwide is actually quite big. So those who are coming from the private hospital, just make sure that your managers are informed about this risk, okay? And second thing, make every effort that once you quantify it, you document it. So you quantify it and you document it. This is actually very, very crucial, for your own bit. No, not everything, okay, but especially the extreme risk or the high risk. Because sometimes, you do not have resources to do it. Sometimes you do not have resources to do it, okay? But as far as you actually highlight to the chief executive, they look over here, these are the extreme risks, and I want A, B, C, D, and they don't. That's okay. You have done your best, what you can. So don't actually lose sleep over it and have nightmare and actually get stressed out about these sort of things, okay? Once you document it, that's it. Now, this is a 2x2 table, which is very simple. Now, this will be very, very different for different hospitals. So let me digress a little bit to actually give you about the risk. And now, in hospital, there's nothing to do with infection control. I'll tell you a very interesting story. In our hospital, we had a snow in December. So when a patient came in, it was visitor, slipped outside and actually got fracture. So the patient, the visitor actually took us to the court. And they asked, the judge, we were there, judge asked one thing. Do you have disinfectant, do you have a gritting policy? That means you look at the weather and it's snow, then you grit. Basically you put a salt to make sure, snow is melt. So we said, we don't have it. So what happened? 0. We will not find. So that's okay. So the judge say, okay, what you do, you actually have a grading policy. Yeah. So now we have a grading policy. 2 years later, one patient actually fell. Okay? And he took us to the court. So what do you think the judge will say now? Because what I'm talking is about documentation, okay? Just to actually give you an example. So what actually happened? We were fined 30,000 this time. Why? Because say you have got policy, and because you have not implemented the damn thing, you did not actually tell the person to go and look at the weather condition in the evening. Your policy you did not implement it, 30,000 quid. So we were done. Okay? Second case about the risk management. We have a patient actually, and this is about the linen and laundry, okay? Cross-infection. We have a patient actually, 78-year-old with 56-year-old girlfriend, okay? Came to our hospital with diarrhea. So the nurse actually gave soiled pajama, because in UK, you know, anything which belongs to the patient is their own property, okay? I mean, we lock it, we log it, we sign the damn thing, you know, it's really a nightmare anyway. So the nurse actually gave the soiled pajama to his girlfriend. So she actually took this soiled pajama, kept it on the kitchen table, and had a sandwich. And then got salmonella. It was Ojava, okay? So it was a patient who got Ojava, he got Ojava, okay? The exactly identical strain, and we typed it, the whole thing. We went to the court, okay? So I went to the court, and I said, no, we are going to fight it. I mean, this is really, really stupid, isn't it? In terms of risk management. This person had no idea of concept of risk management at all. That how you can actually have soiled pajama and actually have making a sandwich, and if you don't get salmonellosis, it's God's miracle, okay? So she was suing for 35,000. Now, we went to the court, and I went to the court, and I went outside, I'm going to fight the whole thing. And eventually, you know what happened? We lost the case. Why? Because we did not inform the patient, neither we documented, okay? So although the nurse actually said that when you go over, you make sure you put pajama on the side and then wash it, but it was all verbal, right? She did not document the whole thing. So we have no documentation, no evidence, nothing is written, nothing is documented, we are done. Okay, so we lost. So we have to pay 35,000 pounds for this sort of thing. Now, you come to the hospital, in whole of United Kingdom, you come to my hospital, we have, so the judge actually say you have to have a laundry policy, that when you give the soiled pajama, we have instruction to, you know, to say, please, God's sake, wash your hand, don't actually put the soiled pajama and make a sandwich on the damn thing, you know, all these sort of things. So we have this policy. Would you imagine the whole United Kingdom? We are the only hospital who have got this stupid policy. Now, if you would have documented the thing, yeah, in terms of risk, then we will fine. So we were done. So we lost the case, you know, I lost the case, you know, I could not. So anyway, so there are lots of other examples I can give you, but I don't have time because I'm just digressing into a different way. But I want you to remember, you know, these things which are actually happening, which are real life, okay? So life, you see, as a microbiologist, is really, really very interesting, okay? So it's not really, if you keep on thinking, it is really. Okay, so if you actually do this 2x2 table, remember one thing. This table will be very, very different to Jipmer, to Hospital in Apollo, to Hospital in Calcutta, whatever it is. They will be different. I just want to give you a small example. So high frequency, high severity. A lot of people are using needle and syringes again and again, right? So frequency is quite high, you know, if they keep on reusing it. The severity is high because it may not be acutely severe, like patient get bacteremia, right? But the patient may have long-term consequences in terms of hepatitis C, hepatitis B, HIV, possibly liver cirrhosis, yeah, okay? So that will be your priority. Second, high severity and low frequency. So severity is quite high, like somebody getting bacteremia, but remember the device-associated frequency is comparatively low to this one. And then you got low severity, right? Like you put a catheter, and person get UTI, take the catheter out, give a little bit of trimethoprim, and the patient is fine. So the severity will be less. And then this is the linen, for example. Now, you can actually have this 2x2 table which will be completely different. So let's actually summarize the whole thing, what I'm trying to say. First, I think you must document. You actually look at the probability and the consequences. Document 2x2 table, put things into this perspective, and then please document and inform your senior manager, your line manager, whatever it is. So this is, because unfortunately, the whole world is actually going towards this litigation, okay? And I give you a few more examples if I've got time, and they are really, really interesting, because in 30 years I've been to court so many times, okay? Just to defend the clinician on the infection prevention control, and they were really doing stupid things. So you see, this is what I'm trying to say. When you say in India, we have got this difficulty, no, I'm telling you, my difficulties are actually no better or worse than yours. It's just they are different, okay? And that's what it is. So first you identify risk, you analyze it, and then you try to control it. Then you actually left basically with 3 options, okay? So you try to avoid it or eliminate it. So say, for example, you have got people are reusing needle and syringes. If you have single-use disposable syringes, that means that risk is completely eliminated. How you can avoid it? You can avoid it. Say, for example, your CSS is not functioning properly, yeah? You can outsource it. Your laundry is not actually functioning up to the standard. Outsource it. Okay, that's much more cost-effective. So that's sort of avoidance, yeah? Either elimination or avoidance, depending what you are going to do with that sort of thing. So that's the first thing. Remember, this is a science of risk management. So you have to think it very clearly. So next time when you ask me, because people are asking me lots of questions, and I think when they're asking this question, I don't think that they've done the risk analysis, because their problem is actually something different, you know what I mean? These are not the problems they are. Second thing, you can reduce and you can minimize it, okay? So say, for example, you've got a lot of problems with central line infections or peripheral line infection in terms of by education training, you try to actually minimize the number, which I've shown you, so you can do that. Or you just accept it. They look over there, low frequency, low this, cost is phenomenal, this is not the priority. Now, who is going to actually make that decision? You? No. You can't make that decision. It has to be senior management. They look, I'm actually telling you, as infection control, that these are the risks you have if you're not going to do this bits and pieces. And he said, yes, I don't have funding this year, maybe next year I'll give it to you. But this year, I'm documented, I'm going to accept that risk. Why? Because the priority is actually quite different. So here's an example. When I was clinical director of the pathology, our reports were actually getting quite late, yeah, to the patient. And the GP were complaining. So I really needed 2 people, okay? And we have got sort of, we have got 9 clerical staff, okay? And all of them, they were female, so we have got outbreak of pregnancy. So 6 staff become pregnant, okay? And suddenly we have 3 people, okay? So I went to chief executive and I said, look, I really need this staff, you know what I mean? The reports are actually getting late to the GP is because the 6 staffs are pregnant out of 3, so 3, I cannot cope with it. So how much I need? I need about 30,000 pounds. You know what he told me? He actually told me he will accept the late result to the patient. Why? Because half an hour ago, a person came from the States, and he told me our water tank, right, reservoir, is literally leaking. And if you don't actually mend that one, okay, then the hospital will have no water supply. So he said, I'll accept it, so that's okay. But can you see, I've shifted the whole thing. For him, the priority was leaking water, yeah? Because the operation and the whole thing will be completely cancelled, you know what I mean? Versus me, GP getting a little bit late. Not to worry, you know why? Because if they're abnormal, we were ringing them anyway. So there was no issue with that. But can you see, this was the risk assessment he's made. But we decided that we are going to accept it, and now we are going to make money. We were going to ask the Department of Health to ask blah, blah, whatever it is. Anyway, so it will came. But I just want to give you a few examples, you know, which happened over here. So risk analysis, when you're actually doing, just keep on thinking. Where they are happening, is it all hospital? Okay? Or is it just one particular area? So you just don't say, I've got a problem with central venous catheter. No, I'm sorry, no, I don't accept that. Where is the problem? Is it intensive care unit? Is it your neonatal unit? Is it your ICU? Is it your A&E? Try to actually quantify where they're actually happening. Why they're happening? How often they're happening, the frequency, and how much they're going to cost to prevent it. So this is a very formal way of actually thinking it. So just not say that I've got a problem. The answer is keep on digging it. Have you actually seen, have you heard the concept of 5 why? Okay. If you've got a problem in your life for infection control, okay, keep on asking why. And say why it has happened. Write it down. Why? With 5, when you come to 5th why, you always get the answer. Why infection? Why this person did not wash the hand? Why? Because the person was new. Why when the person was new, we have induction program. Why she was not trained? She was not trained because we were short of infection control nurses. Why, when we were short of infection control nurses, what I did as the infection control, you keep on doing why. So remember this concept of 5 why. We keep on asking 5 why. Keep on asking this question, even in your life about the car and everything, you will get the answer. So this is the grid you actually use. So this is your infection frequency, infection control measure. So these are the cheap and these are the expensive ones. So this is the one you keep on targeting it. So remember now we've got so many problems, you keep on focusing and narrowing down, yeah? Okay, now this is the exercise I want you to think, okay? And this is the trick question, okay? So think about it, and I need the answer. I want to raise hand. Think about it, because this is the way I want you to drill in your head about the concept of risk management in a very subtle way, okay? This is why you are actually running like a headless chicken, okay? So let's talk about this. Now, if you actually have this 2 by 2 table of grid, the things which are urgent, not urgent, yeah, but important. The things which are, urgent and important, yeah. The things not urgent, not important, urgent and not important. So which grid, okay, you are infection control nurse. Which one you are going to do first? Pardon? This one? Yes. What about this one? This is number 2, number 3? Okay, so you're actually saying this? Okay? Okay, it's wrong. Why it is wrong? That if you are actually doing this one, you have no concept of risk management, and you are running like headless chicken. Why? Okay, now you think, you have to tell me, I need a break, okay, you have to tell me why. Think for a couple of minutes, why I'm thinking, I think this is one. Why you think, if I reverse it, and if I say this, yes. See what actually happened? See what actually happened as an infection control nurse, we are running like headless chicken. We do not have time to think. So just actually make sure that in your weekly schedule, okay, in your weekly schedule, you actually spend at least half a day or 2-3 hours as infection control nurse or doctor, whatever it is, a team, just to actually keep your mind quiet and think proactively. Remember, number 2, the things which are important, but they are not urgent. They are fire prevention. Important, urgent are actually controlling outbreak, yeah, for example. Firefighting. You are in this mess because you have not spent time on the first one. So what actually happened in the real life, okay, in my life? We are just working, keep on working. Not actually thinking what the issues are, okay? So remember, because it should be this. But you have to actually, in your diary, just make every effort. I do it. You just make every effort. You got a couple of hours, a thinking time, you understand, when your heads are clear. Preferably morning and no disturbance at all. Tell your secretary if you have it, to take off your call and think what the issues are. Bring your team together, but think. That is going to save huge amount of time, honestly. Because urgent and important is panic, yeah? It's outbreak. It's crisis, okay? That's what it is. Now, here's an example. Say, for example, if your car, when you start, it starts, sometimes it doesn't start, but it's working, okay? So you know it's important, yeah? Because you have to manage your car. But it's not urgent. When it becomes urgent? When it doesn't start at all. Then you have to get the mechanic, Then you have to get the mechanic to think, this is urgent. Now you work for late and for the meeting, all these sort of things. That's firefighting. That's urgent and important because urgent, it doesn't work. It's important because you have to be in the meeting and you have to be at work. If you go back, if you know it's not starting, there's the problem. It's not really urgent. You know why? After 2, 3 start, you can actually still go back to the work. But to get the things right is important, yeah? So think in that way. So remember, it's number 1, which is important. So basically, it's basically about priority setting. This is the area where you set your priorities. This is the area what I've told you actually to gather all this information. This is the area where you say, this is what I'm going to do. This is what my team is going to do for next week. Okay, so you don't actually do. And once you actually do that, you prevent it. Okay, so this is urgent. So this is, remember, this is reactive. Sorry, this is proactive. Priority setting, strategic planning. How many people of you who have a 1-year infection control plan? Most of the hospitals, they don't have. This is where you are going to actually sit and the next year our plan will be this. Why? Based on risk assessment, based on priority, which could be departmental priority, which could be priority from the government, priority from your hospital, priority in terms of patient safety. It could be any of those, but you have set all those sort of things. So you have to have strategic planning, please. You have to have. You have to actually have a half a day, a couple of hours, completely away from the whole thing, okay? Life will not end, I'm telling you, if you spend half a day, because sometimes you can become sick and ill because of flu and don't come. Hospital are not going to collapse. No, isn't it? So, but take some time out as you think about it. So, I just want to actually show you now how do you, remember, work smart, not hard. Now, how many people actually have about the Pareto Principle, 80-20 rule? Can you raise your hand? It's called Pareto Principle, 80-20 rule. Have you heard about this one? No? Okay, I work my whole life based on this principle. Okay, 80-20. Okay, go back. I give a couple of examples. Go back and look at your home. 80%, pardon? Hello, yeah, okay. Okay. It's called Pareto Principle. This is very important things which I'm going to say. Apply this to your life in every way, okay? If you look at your car, 80% of the car, you're actually sitting in the area with the 20% of the time, the front seats. If you look at your house, which is your dining room and TV room, and 80% of the house you're utilizing for the 20% of the time. So it's 80-20. So look at everything, you know what I mean? So what we are trying to say that, so let's go a little bit and then I show you. What actually happened, this is the Pareto Principle. He was a 19th century Italian engineer who discovered the distribution of wealth. And he actually said, look, 80% of the wealth at this moment is actually held by only 20% of the people. Then he became very interested, you know what I mean? And said, what actually happened with the other economy? And he actually found that he didn't discover that 80% result attributed to only 20% of the situation other than economics. So he went and actually found out the company. 80% of the revenue coming only from the 20% of the client. Okay, 80% of the complaints are actually coming from the 20% of the people. Okay, it's 80-20. Okay, so it could be 19, it could be 80, but 80-20. Look at your house. Certain area you're utilizing 80%. Okay, which is I can tell you your dining room and TV room and that sort of thing. Car is a similar kind of thing. Okay, front bits to 1 or 2 seats are actually 80% are utilized. So this 80-20 rule. So you have to apply this to infection control. Remember, now you have priority setting. So remember I've told you, work smart, not hard. So if you don't plan, you are actually working very hard, chasing your own tail, not achieving everything. Why? Because you do not have a set goal. You don't have to prioritize it. So think, do not have resources. I only have 20%, I have a very limited amount of time. So I have to think very clearly what I'm going to do and what I'm going to do effectively, yeah? Rather than just doing it for sake of doing it. So this is called 80-20 rule. So remember, focus on vital few and forget the trivial too many, which are 80%. So this is the most important bit. See, if I'm going to do this particular one, and this is going to give me 80% of the result, by putting 20% of the effort, that's the one you should go for. That's priority setting. And that's actually give you, remember throughout the whole presentation talk how you're going to do it, and then suddenly you actually do and have a thinking time, you actually come to this kind of conclusion. And it works actually really, really well, okay? And this is the reason, remember when I was actually talking of the infection prevention, my hospital, remember I showed you a slide, is actually based on this particular principle. So what you do, you go to internet, and there is a Pareto chart. You put all bits and pieces, it'll give you a nice graph. So idea is basically you pick the low-hanging fruit. Don't actually waste your time and energy in climbing the big tree to pick the fruit, okay? Pick the one which are low-hanging, whatever it is. Now this is the Pareto principle, Pareto chart. So can you see when you actually put all the information on the Pareto chart, it will give you this Pareto chart. So can you see now, this hospital got problem with MRSA bacteremia, okay, right? Where you're going to concentrate. Basically is a medical ward and surgical ward. So first you have to tackle medical ward, then surgical ward, rather than actually tackling the whole thing. So I'll give you an example of the blood culture. And in fact, my colleague, who is from this part of the world, okay, from Kerala, and we were working there, he came to me, and he said, Nizam, we got a lot of problem, with contaminated blood culture, with staph epidermidis. Remember, we have a problem. And he wrote a very beautiful letter, writing to all the clinicians and the doctors, and we got this problem, this problem, this problem. So I said, Raj, sit, okay, let's actually have a conversation. This is what I see. When you are going to write this letter, the clinician will get very annoyed because they will have so many letters coming in. So I said, tell me, give me a few information. Have you analyzed which hospital? Because you have 7 hospitals, right? No. I said, go and find out. He actually came with the hospital. It was one hospital. Okay. Then he said, I said, okay. So he said, now we have to write to the clinician to that hospital. I said, no. Give me the ward. Suddenly it was pediatric ward. And he said, I want to write to pediatrician. I said, no, you are not going to write to pediatrician. Bring all the form now. And, find out the doctors. So it seems to me that 2 doctors who were not trained, right, who was locum, creating 80% of the contamination. So rather than writing to everybody, I got this doctor, trained how to take the blood culture, and the problem disappeared. Yeah? But you see, can you see what I'm trying to say? What I'm trying to say is that when we have this problem and we don't have this kind of information, we try to lambast the whole thing. So try to think what the issue is. Try to actually work out the Pareto chart. So can you see the amount of hassle which I've sent just by training these 2 doctors who were cause of the 80% contamination? And it was not even the ward, isn't it? Because when you actually send to this letter to clinician, they get very annoyed, you know what I mean? I'm doing the right way, you know what I mean? But we sure look over here, I'm sorry to say, because now I've got facts and information, yeah? I've got fact and information. So look over here, I'm sorry to say, we looked at all the doctors, and this is the Pareto chart in which you 2 needs to be trained, and that's all. So remember one thing, don't chase your tail. Identify the infection which are preventable. Target preventable infection in high priority area, which require minimum resources and maximum benefit, which is 80-20. So keep that principle in mind, because the question is, can you eat elephant at a one go? No. But can you eat elephant? Yes. The answer is it has to be in bite-sized chunk. You take a little bit of it. 80-20 is about that. Okay, you can't eat elephant. It's 100%. Little bit you can eat it every day. You can finish it maybe lifetime, but you can eat it. Yes, you can eat elephant, but you can eat it in bite-sized chunk. So this is all about that. So this is a bit which I was saying. So if I summarize the whole thing, so basically what we are trying to say, that look at the unsafe practices, the pastries which are ritualistic and wasteful, right? We talked about that, and the list is actually very long. Divert resources into evidence-based medicine and the things which are cost-effective, right? And bring it to the gram irreducible minimum. Why? Because live in low resource setting, because sometimes you may not have, you will never, ever achieve zero infection rate, ever. Forget it. It's not going to happen. You may reduce it 5%, 10%, 15%, 20, 30, 40, 50, whatever it is. But you have to bring to as much as you can. So remember I told you, even 5% in your hospital, in this hospital, 5% infection rate. Look at the number of thousands of patients, yeah? Thousands of patients you are talking. Just the scale is quite big. So, and then you need this audit and you need surveillance. So you need this data and you need thinking time, you need this Pareto chart, and you need to organize the whole thing. So this is the really bottom of it. So just want to give you a couple of examples that if you look at because we have a problem with MRSA because the government set a target that we have to reduce MRSA by 80%, okay? So can you see, we start working on it, and then 2003, we got MRSA, we really see MRSA now, okay? This is all device related, line related, okay? So can you see reduction over 90%, yeah? But also we've seen reduction also in the MSSA. MSSA are complicated because people are carrying it there more, but MRSA is a surrogate marker of infection. Look at Clostridium difficile. We were one of the worst hospitals after intervention. We are now one of the best in the whole UK. Okay, so we see about 80% reduction. So our target was two things. Remember, first was central line, and these were political issues for us, kind of thing. So this is my last slide. So what is the take-home message? How many people have been to Amsterdam airport? Okay, if you go to Amsterdam airport and go to the gents toilet, there is a fly attached to it. And what they actually found that when people were actually going for the short call, they were creating a lot of mess. Okay, so they want to control the mess. Okay, this is actually based on 80-20 principle. So what they did, so they attack the fly. So if men see the fly, he aims at it. It gives something to think about. Okay? And the fly and the urinal found that this actually exactly reduced 80% reduction. Okay, so so these are all signs. So can you see a small intervention? This is what we call nudge. Now, if you really want to read a very interesting book, because I've got so many books to quote over here, the one book is called Nudge. Okay, have you read Nudge? Okay, read it. So say, for example, have you got 5 minutes? Okay, so let me give you a few examples around here. Say, for example, if I actually tell you to exercise or eat good food, you're not going to do it. So what happens if you go to supermarket? Yeah? If you go to supermarket, what they are trying to do in UK at least, they're actually keeping fruits and vegetables and all the healthy thing at the eye level. So what happens psychologically? You actually pick the one which you normally don't look at the bottom. Okay? If you go to supermarket, they want to make more profit. What they try to do is to anything which is at the eye level are expensive, where they make more profit. The cheaper stuff will be always down. Okay? So when you look at the supermarket where they are keeping a lot of frozen things, because of the staff turnover, rotation of staff, they always keep the items which are going to expire in the front and the one which is along the back. So I always go over the back. Okay? The second thing, the nudge they use, so if you look at the supermarket, if you look at the stores like Marks and Spencer and things like that, if you've been there, so what actually happened, that they've got slow music, so you slow down. Okay, so you're relaxed now. Okay. Second thing what they do, that this is hard floor. psychologically, I'm actually running, yeah? Once I actually see the carpet, psychologically, I slow down. So they keep all the clothing on the carpet side, okay, with slow music, and the other one, you keep on running, and as you see the carpet, you stop, and you start buying the clothes, okay? So there are loads of examples I can give you, and this psychology has been used a lot in healthcare, and there is in United Kingdom, there's a nudge unit, okay? There's a nudge unit which actually does that. So this is actually quite important. So what I'm going to say, that this is actually quite thing. So exactly 80%, when I target these 80-20 things, I exactly reduce 80% bacteremia and Clostridium difficile after IPC intervention based on that one. So I work, it is working of smart rather than hard kind of thing. So take-home message is very simple. Focus on the target and execute, and you will create less mess for your patient. Okay, thank you.